secretion is basically highest during night and lowest in the morning. Cholinergic and histamine stimulation is the one which is required for maintaining the secretion. And stimulated one is important. It has got three phases. Cephalic phase, which is basically activated by the taste, smell and the sight of food, or maybe a boring lecture before the lunch break in this conference. There could be a gastric phase, which is because of stimulation of the G cells, which secretes the gastrin, which may be done directly by the food, or it can be because of the various neurons which are situated within the submucosa. And of course, you got the last phase, the enteric phase, where the food enters the small intestine, and then you can have Now, PPI are the ones which are important for management of all this. See, we said that there are multiple phases of stimulation of the stomach or gastric mucosa to produce acid, but ultimately they act through a common pathway which is called as the proton pump. Now, you need a drug which will back the proton pump so that all stimulation coming to the parietal cell is blocked by the drug and the acid production is dramatically brought down. They were introduced in clinical practice in 1980. They revolutionized the treatment of acid peptic disease. They irreversibly block the proton pump in the parietal cell, thus they block the pineal pathway of the acid production. One of the most widely prescribed medicine all over the world. 15% of the population and those who are more than 60, almost 40% of them will have used NSAID proton pump inhibitors at some time. You have got various drugs in the proton pump. You have got omeprazole, you have got esomeprazole, you have got pantoprazole, rabeprazole, lansoprazole, etc. All of them are labile to the action of the acid. So for the action, they must become activated in the duodenum or in the small bowel. That's why they come either as enteric-coated tablets or they come as enteric-coated granules. Pantoprazole is luckily available in the form of IV also. I almost get disheartened every time when in ICU I see people are giving Pantocid. They break the tablet and insert it to the Ryle's tube. Not done, because it gets inactivated within the stomach. So you can't have Pantocid. There are preparations like omeprazole which are combined with bicarb, and then the bicarb will protect the acid degradation of the omeprazole, and then probably you can administer. PPIs are basically lipophilic compounds. They enter the parietal cells where they are trapped within the tubulovesicular as well as the canalicular structures where the proton pumps are situated, and this is where they will irreversibly block the proton pump and then will not allow gastric acid to be produced by all three phases of stimulation. They got rapid onset of action within 2 to 6 hours. The action persists for almost 3 to 4 days. After a week of administration, almost 95% of the acid production is blocked by the drugs. Maximum activity is when the proton pumps are active, that is in the morning, so preferably they are given before breakfast. Proton pumps, of course, we must come to use and misuse. One of the most misused drugs, easily available over the counter, not very expensive. It has got great safety, so is prescribed left, right and center. Inappropriate symptoms, inappropriate duration, inappropriate indication, inappropriate dosing, everything is inappropriate when proton pumps are used, unfortunately. Observational studies have shown that the proton pump misuse is more than 60%. Now, here there are certain examples. Any casualty you go at 2 o'clock with some pain, you will get standard 3-4 drugs. You will get one PPI intravenous, you will get one parafalgan, you will get MSAID, and maybe something else. I do not understand the logic of giving IV PPI in a patient who has come for some discomfort, followed by rabeprazole twice a day. I do not know what it is given for, but this is a common prescription right from Churchgate up to Virar. The same things will be repeated here. For the not showing the names, I will go to the next slide, but the previous slide showed that some patient was given 2 PPIs at the same time and 3 prokinetics in the same prescription. 2 PPIs probably may not do great damage in a short term. 3 prokinetics can definitely produce Parkinsonism in an elderly person. You must realize that I see a lot of prescription coming from doctors who have to use it because they use painkillers, where standard is Pantocid DSR twice a day. Now, what DSR twice a day for? You are giving 60 milligrams of domperidone, which is in long term going to produce external side effects. Please don't that. It is not required at all. There are definite indications for proton pump inhibitors. Some of them are for short term, some of them are for long term. Short term are of course basically because of atypical esophageal symptoms. Dyspepsia, either undiagnosed or because of NSAID, it may be because of stress, it may be used for stress, ulcer prophylaxis, mucositis because of CT or RT. When we use banding for esophageal varices, they need to be given for short term. Helicobacter pylori eradication is very important. 15 days course is required. We of course give prevention of rebleed from mallory syndrome, which is a tear at a cardiovascular junction. Long-term side effects are, many of them are in the GI, so I will just quickly mention. They are basically related to esophagus. Reflux esophagitis of severe degree, which may be erosive or non-erosive, peptic stricture, bleeding from esophageal, because of esophagitis, Barrett's esophagitis, related to eosinophilic esophagitis. All these conditions will warrant the use of PPI for a long term. So far as orthopedic surgeons are concerned, when you are using for osteoarthritis or whatever the indication is, you must be watchful that you are using it sparingly, shortest amount of drug, smallest possible dose, and the duration should be as less as possible. They are not to be used or used to be cautioned or should be combined with PPI when you are giving it to a person who has a history of acid peptic disease in past or who definitely had a history of bleeding earlier. These few things you must keep because you really use it for a long time. That's why it is necessary to remember which patient you are entitled to use it for a long time, otherwise you may land with the side effects of the drug. Long-term use is definitely been advocated for various GI conditions, but so far as orthopedic surgeons are concerned, recurrent aspirin or NSAID-induced gastrointestinal ulcer or history of ulcer or upper GI bleed, they definitely need long-term treatment. It can be used as an intermittent also, specifically in GI conditions like reflux hypersensitivity, functional heartburns, along with short course of NSAID, important for this audience. Commonest indication in general practice is dyspepsia, gas, burping, belching, reflux, acidity, you name it, and it is given for months together. Recurrence rate is very high in this group. On-demand therapy also should be done, that is especially for my specialty. Misuse can be because it is inappropriate use is at every level, starting from interns to general practice to casualty to medical and surgical wards to ICUs, you know. There has been a study in tertiary center teaching hospital. Indoor patients 62% received PPI, 22.7% OPD patient. Appropriate use was only in 7.4%. Inappropriate use was in 91%, and probably appropriate use was in 1.6%. So you can imagine the magnitude to which PPIs are used indiscriminately. 12% of the total cost of medication was spent on PPI. Same thing for when it comes to admitted patients, when intravenous PPI, especially in ICUs, they are inappropriately used in 90% of internal medicine indoor patients and 34% in surgery. So surgeons are doing better than physicians here. The IV are expensive, they increase the burden of the sisters, they need to be approached through IV route, so you expose the port to infection again and again. They are also used empirically by everybody, chest physicians, ENT surgeons, general physicians, for non-specific symptoms which are related to larynx or to the pharynx, not to be done. Adverse effects of the long term may be related either to long-term inhibition, which are not related to acid inhibition but something unrelated. Most common side effects because of the prolonged use and acid inhibition. Main causes of misuse of proton pump inhibitors are patients on steroids only, patients on SSRI, that is psychiatrics, they use these drugs. In your specialty, NSAID, ASA or coxib use, patients on low molecular weight heparin or antiplatelet drugs or warfarin, patients who have need stress ulcer prophylaxis, yes, should be given, but if they are not in ICU, there is no need to use it for them. Wrong diagnosis, wrong duration, cirrhosis of liver, random they are prescribed, which is harmful to the patients, improper and continuous prescriptions without even looking at it, and the person who is on scene is never willing to go back and check whether it is indicated or not indicated. There are certain side effects which are unrelated to acid inhibition, and they are mostly allergic manifestations, like maybe bone marrow suppression producing all 3 cell lines can go defective, or there may be dermal like epidermolysis, necrolysis, or Stevens-Johnson syndrome, interstitial nephritis, etc. Collagen colitis is also known because of stimulation of collagen expression in the colonocytes. Acute interstitial nephritis, yes, it's supposed to be anaphylactic type reaction. In fact, 14% of the total cases of drug-induced nephritis are because of PPI. Long-term PPI are associated with CKD also. Increased cardiovascular risk because they block the clopidogrel, the antiplatelet drugs action. That's why they can increase the risk of cardiovascular events. They also are responsive associated with dementia. Now, adverse effects related to acid inhibition. One is they block the antibacterial immunity by reducing lysosomal activity, so high chance of pneumonia. Because they suppress the acid in the gastric environment, that's why there is high incidence of Salmonella, Campylobacter and Clostridium difficile. They are also known to produce neuroendocrine tumors because of hypergastrinemia. They alter the gastric microbes and they are responsible for small intestinal bacterial overgrowth with the symptoms related to that. That is because of the acid in the stomach is neutralized by this, is not allowed to be produced by the drug. Gastric acid is important for digestion of protein, iron, calcium, magnesium and killing ingested bacteria as we saw. That's why it can result in hypomagnesemia, it can result in B12 deficiency, it can produce iron deficiency. There is an increased risk of fracture probably due to decreased absorption of the calcium and impaired activity of the osteoclasts and maybe osteoporosis. Funding gland we need not bother. The other side adverse effects are, one is high associated increased incidence of malignancy of the stomach and colon. In cirrhosis of liver, spontaneous bacterial peritonitis and hepatic encephalopathy, risk of drug intolerance because of drug interaction at every level, absorption, metabolism or excretion. There is increased risk of pneumonia in 67%, hip fracture in 42%, colorectal cancer in 55%, also high risk of kidney and cardiac disease and Alzheimer. Approved indications for long-term use are, we will not go into the GI. Important for you is prolonged NSAID use when you are using it in patients who have got increased risk of either ulcer or increased risk of bleeding. Conclusion is PPIs are wonderful medicines but are being misused for indications not meant for and for prolonged time and in appropriate doses. So wrong indications, wrong doses, wrong duration of treatment. There are concerns are going, but they are irrepressible so far as management of certain disorders are concerned, and they must be used because the advantages definitely outweigh the disadvantages. That is in severe reflux esophagitis. For you, when you are using long-term NSAID in a person who has got gastroduodenal ulcer history or history of upper GI bleed. The studies have identified an association between long-term use of PPI and a lot of side effects that we talked about, but there is no causal relationship yet established, neither there are confirmed RCTs for that. These are mainly observational studies. But remember, nevertheless, in view of increasing awareness of these adverse effects and indiscriminate use of PPI for invalid indications, prescriptions for defined indications must be in the lowest possible dose for shortest duration. If the use is unjustified, then effort should be made to eliminate that particular drug. This is my favorite slide, that's the Everest there. I will just take another 30 seconds because this is important for you. Establish risk factors for GI side effects due to NSAID. Probably Anil must have covered, but I will just go through it again. Advanced age, history of ulcer or GI bleeding, concomitant use of steroids, high dose and prolonged use of NSAID, multiple NSAID used at the same time, concomitant use of anticoagulants, clopidogrel, serious multisystem disease. So, if you are using NSAID and patients have got this associated factor, be careful, make sure you use in appropriate doses for small time and use PPI along with that. And there are certain possible risk factors for GI side effects due to NSAID. Possible, earlier are confirmed risk factors. Possible are concomitant H. pylori infection, smoking or alcohol consumption. Need not go into the smoking. Last is a very boring slide. But what we said earlier is summarized that these are specific chronic disorders which have got high incidence of APD and or pelvic or peptic ulcer disease. And when you are using it in these patients, as there is a high risk of peptic ulcer disease, you should be cautious about using the drug. Otherwise, you can land up with this severe esophagitis that we saw, or maybe a massive bleeding. Can you see a big vessel there which is ruptured because of use of NSAID in a 78-year-old person? And of course, then we put the clips and control the bleeding. Thank you so much.